that are more than willing to answer the questions that you have. So, Dr. Qureshi, in some cases, when colon cancer is considered advanced, stage 4 of course, and it has spread, is there still a role for you as a surgeon to step in?
Right. Okay. So essentially in stage 4, we are looking primarily to make sure that the patient has the best quality of life. So there may be some patients with a very small tumor, okay, but with spread to liver and lungs and elsewhere. Now, these patients, even though surgery is possible, but may not benefit the patient. So in those patients, perhaps surgery should be avoided. But then there are patients where perhaps the tumor is either bleeding or it's almost causing an obstruction. Despite the fact that they have stage 4 disease, surgery may benefit them because it will give them a better quality of life. So each patient, okay, is evaluated, holistically, and we make a decision based on that. So it's really what's best for the patient, not what's best for the oncologist or the surgeon, and that's how the patient should be approached.
Thank you. Thanks for that, assurance to patients out there. My last question is to Dr. Jenson. I think you mentioned about stage 4 earlier, and it can sometimes be complicated. So is there anything you would like, because we are talking about hope and healing for colorectal cancer patients, is there anything you would like to share with the audience, especially for those who were diagnosed with advanced stages of colorectal cancer?
Right. So I would like to add on further to what Dr. Qureshi has mentioned about in the advanced disease, where when we say that in stage 4, not all stage 4s are the same. There are cases whereby stage 4s whereby the disease spread to the distant organs are limited. And there are also cases whereby because of the treatment that now currently available, we are actually looking at a much higher response in those patients. So in terms of role of surgery here, it's not completely, it's all lost. There are cases whereby that by giving a systemic therapies or chemotherapies with targeted therapies, or in circumstances whereby immunotherapies come into play, these patients, if they achieve a very good response, potentially these patients still have the chance of going through a curative surgeries, which means that removal of the primary tumor from the colon, as well as depending on the tumor site. For example, it's very common that we see in colon cancers the tumor spreads to the liver or to the lungs. But if the disease are limited, means that there are not that many tumor spread to these areas. Potentially, these patients still can undergo a curative surgery, which means that removal of the primary from the colons, as well as some part of the liver resections or the lung resections. So we are still, as oncologists, still always try to aim for achieve a potential cure in these patients. So, like I said, all hopes are not lost. There are treatments that is available. The only thing is that we just have to find out exactly what kind of treatment is the specific for that particular patients and how we can personalize the treatment. And I believe that all treatments can be, tailored accordingly. Yeah.
Thank you so much to both Dr. Qureshi and Dr. Jenson. I think today we are here to address colorectal cancer as a whole for those patients who are currently undergoing treatment and who are recently diagnosed. And we want to let you know that there's hope out there because there's so much modern advancement in terms of technology for treatment. So the most important part is to equip yourself with the right information and the right doctors, the knowledge that you need when you're diagnosed. And that's why we have Talking Live with Mei Sze. And now I'm going to start taking questions. So if you have questions, you can put them in now. I have one question. I think it's about a home pharmacy test kit. So Recently, Madam Yo saw a pharmacy selling a home test kit for testing of colorectal cancer using stool.
Yes.
How would you say is accurate? How would you say this type of test, the accuracy of the test?
So really, we're talking about screening tests. Okay, so screening test is basically using a test to try and identify the cancer in the population at large. We can essentially divide screening tests into three different types. One is a stool test, second would be a blood test, and the third would be some sort of an imaging test. So a stool test, the oldest one is the FOBT. So that's
FOB.
fecal occult blood testing. So that looks for blood in the stool. Now, this test is or really was so sensitive that even if you say if you had a beef the night before, okay, and you tested it the next day, might prove positive. Or if you brushed your teeth very hard, a tiny little bit of blood can still be detected. So then they developed this FIT, which is the fecal immunochemical testing, and that avoids the need for dietary restriction and tends to be more accurate. Okay, and of course there are newer fecal tests which look at specific antibodies and the hemoglobin in the blood, although they're not as commonly available. So the FOBT and the FIT are the most common. Blood tests generally not as good, particularly things like tumor markers. The specificity and accuracy is in the region of about 30 to 31%, so really poor. And in fact, people with lung disease, kidney disease, smokers have abnormally raised tumor markers, and that again sways it. Imaging tests would be things like, for example, colonoscopy, CT colonoscopy, or even a barium meal. So of course, colonoscopy is the gold standard, but unfortunately, it is more expensive, and you need a bowel prep, which, as you know, is not really the most pleasant thing to take, and it requires sedation, and it of course has got risk. So as far as the fecal tests are concerned, they are generally used for the population at large, and there are some countries like Australia where everybody over the age of 50 is sent one of these kits, on maybe 2 to 3 yearly basis, and then and if that's positive, then they're invited to have a colonoscopy done.
Okay, so I think the next question is, I'll take this one, is, doctor, for a patient with low rectal tumor and MRI showing mesorectal fascia involvement, would you recommend neoadjuvant therapy before surgery, or is primary resection an option?
Yeah. So
I think
this
for
is
you.
something that we discuss all the time. I discuss it with him, and normally we will look at the pictures together with the radiologist, and in the vast majority of these cases, they will we would send them for neoadjuvant. The question is really whether they need a short course or a long course. That's really more the question, rather than should they have it. And in general, I think one of my Korean colleagues not too long ago, said that you can divide the tumors into the good, the bad, and the ugly. Okay, the good ones, they have surgery. Bad ones, they get the short course, and the ugly, they get the long course. So these are the ones that are much larger. Perhaps they are infiltrating the bladder or other parts, and they need a reduction in size. They tend to get the long course.
We hope that answers your question, Ika. I think the next question is, I think it's for you, Dr. Qureshi. If a patient is wearing a colostomy bag for life, is there any hope or new technology to reverse it? Perhaps reconstructing a makeshift?
Yes. Okay. So the simple answer is yes. Okay. Now, unfortunately, it is quite a complex and highly specialized surgical procedure where as long as the patient is cancer-free, there is the possibility, okay, of reconstructing an anal sphincter using one of our thigh muscles here, the gracilis. Okay, so it's a very long muscle. So we release it from the knee and dissect it off, and then we encircle it around where the anal sphincter was. So it can be done, but it requires multiple procedures. It requires a pacemaker for that muscle itself, okay, and it can be quite technically demanding. There are artificial sphincters, okay, and again, they have been used, but the availability of this is the main issue, and they are very costly.
Is it available in Malaysia?
Not at the present. Okay, the gracilis muscle reconstruction is available, but the artificial sphincters, I don't know of anybody else who does it.
I see.
Yeah.
Okay, thanks, Dr. Qureshi. I will take one last question.
Lisa, if you may, I would like to add on about the earlier question about the maxillorectal fascia, right?
Okay.
I think that is a very, very very important question because in these circumstances, like what Dr. Christian mentioned, it's always about doctors, surgeons, and also the oncologists to sit down, to go through the case, to look at the imagings. In general, I would say when there is a maxillorectal fascia is involved, this maxillorectal fascia is the part whereby the surgeons need to have a good clearance in order to prevent a local recurrence. So when it is threatened or it is involved, in these circumstances, a preoperative treatment needs to be delivered. And in these circumstances, we're often talking about radiation therapies. So it's something that needs to be discussed, of course, about short course and long course. If it's a fascia that is already threatened or involved, then in these circumstances, we're talking about long course will be the ideal way of downsizing the tumors. That is the gist of it. Yeah.
Okay. Thanks, Dr. Jenson. I think I'll take one last question from Rennie. Hi doctors, how to differentiate between IBS, basically inflammatory bowel disease, and early stage colorectal cancer? Is it through an endoscopic evaluation?
Okay, sorry, IBS?
IBD.
IBD, sorry.
Yeah.
Okay, right. Okay, right. Okay, so IBD is basically an inflammatory bowel condition. So primarily, it can be either ulcerative colitis or Crohn's colitis. Now, these patients are at risk of developing cancer in the long run. Okay, so if the disease is mild, the risk is lower. If the disease involves only a small segment, the risk is lower. So that in itself will give you some indication as to the risk of that patient. Of course, as to how long the disease has been present is also very important. So in order to identify the symptoms of these two, you're absolutely right. A colonoscopy is by far the most accurate. Okay, and as we were discussing just before we started, colonoscopy has developed over the years, and the most recent introduction for colonoscopy is artificial intelligence, where scope is being performed. Okay, the AI is monitoring the surface, okay, of the colon for tiny little polyps, and sometimes these polyps are not very obvious until the AI tells you, look, there might be something there. So it is, very important to have that done, particularly if you've got IBD. Colonoscopy on a regular basis may be warranted, and sometimes you may find that the endoscopist takes random biopsies, not just of any random biopsies, particularly in ulcerative colitis, because if the patient develops what we call change, not quite cancer, but changes that are heading towards cancer, then they may need surgery before it becomes cancer.
That's very interesting. I've actually known of a case like that. So in the end, they actually did the surgery, but it was kind of like preemptive surgery as well.
Precisely, yes.
So thanks for sharing that, Dr. Qureshi. That wraps up today's episode of Talking Life with Mei Sze. I'm sorry we cannot take all of your questions today. And I think thank you so much to Dr. Jenson for continuously coming back on the show. He's a clinical oncologist with Curie Oncology. And thank you, Dr. Aktbar Qureshi, who is a colorectal surgeon with St. John Medical. And thank you all of you for staying tuned tonight. Remember to share this live with your friends and family so they can watch during their free time. And for the next few episodes, I've yet to set the date, but I plan to talk about genetic mutations such as BRCA1 and BRCA2. So we want to understand more about that and how it actually relates to cancer. I think many of you have questions about that. So I want to dive more into that topic in the next coming episodes. See you soon. And for those of my Muslim viewers, Salam Ramadan and Selamat Hari Raya in advance. Thank you. Bye.